World Day is a very important organization of ESRA, and I just want to promote it to all of my colleagues, and also I just want from my colleagues to just try to do something for the World Day and try to involve in it. Just spread the day and try your colleagues to watch and learn something to improve the healthcare in their clinics.
Be part of it. Be part of it and get connected with many people you do not see, but you feel that they are thinking the same way. So be part of it.
We can be proud of all the achievement we have done until now, because it's always for the benefit of the patient. And anesthesiologists always adapt to the patient and to the surgical technique and to the surgeon also. So I think we can be proud of what we have done, but still we can do better and we can progress.
Every day we learn something new and it's worth it. Try it.
Hello everyone, my name is Lestari Sukmono and I serve as the National Chair for Indonesia for the Third World of Regional Anesthesia and Pain Medicine. This year, Indonesia proudly participates through a nationwide collaboration between Inasora and Sp.An.TI under the Indonesian Society of Anesthesiologists, PERDATIN. In addition to our national meeting, Indonesia is represented by coordinated activities across 9 cities, including Banda Aceh, Jakarta, Yogyakarta, Malang, Surakarta, Jambi, Palembang, Padang, and Pekanbaru. These activities range from scientific symposia and hands-on workshop to webinars and community pain education program, reflecting our shared commitment to advancing regional anesthesia and pain medicine in line with the global themes: equity, access, and relief. We look forward to celebrating the Third World Day of Regional Anesthesia and Pain Medicine together with the colleagues around the world. Join us as we work towards a pain-free future.
Hello, my name is Dr. Rizky Ramadana and I am coordinating the Jakarta activities for the Third World Day of Regional Anesthesia and Pain Medicine. Our main on-site events in Jakarta will take place on 30 to 31 January 26 at the Ritz-Carlton Jakarta, featuring webinars, scientific symposia, practical workshop, and multidisciplinary discussion. Through these activities, we aim to strengthen the education, collaboration, and patient-centered perioperative care in regional anesthesia and pain medicine. We look forward to celebrating the Third World Day of Regional Anesthesia and Pain Medicine together with colleagues around the world for pain-free future. See you at the event. Terima kasih from Indonesia. Bye-bye.
Assalamualaikum warahmatullahi wabarakatuh. Selamat malam kepada seluruh rekan-rekan sejawat semua. Malam ini merupakan suatu kehormatan dan kebanggaan bagi kami untuk menyambut sejawat semua dalam acara webinar hari ini dalam rangka memperingati peringatan World Day of Regional Anesthesia. Kami dari panitia penyelenggara mengucapkan banyak terima kasih dan apresiasi yang setinggi-tingginya kepada seluruh narasumber, moderator, serta peserta yang telah meluangkan waktu untuk hadir pada acara ini. World Day of Regional Anesthesia and Pain Medicine ini menjadi momentum sebagai perjalanan dan perkembangan anestesia regional dan juga menjadi kesempatan untuk merefleksikan peran penting anestesia regional pada praktek kedokteran modern. Dengan kemajuan teknologi khususnya penggunaan ultrasonografi, lalu obat anestesi lokal, serta bukti-bukti ilmiah yang semakin kuat, anestesi regional terbukti mampu meningkatkan keselamatan pasien, kualitas analgesi, dan luaran klinis secara keseluruhan. Malam ini kita kedatangan tamu terhormat. Yang pertama adalah terima kasih kepada Dr. Dedi Fitri Yadi, spesialis anestesi dan konsultan anestesi regional. Beliau saat ini bertugas di Bandung ya dok ya. Terima kasih ya dok atas kehadirannya malam ini. Lalu kita juga ada Dr. Bestadi Sukmono. Malam ini hadir beliau. Alhamdulillah, terima kasih dok. Sebagai Ketua Koordinator World Day of Regional Anesthesia NP Medicine 2026 Regional Indonesia. Terima kasih dok atas kesempatannya dan saat ini kita bisa hadir malam ini berkat acara ini. Uh, untuk Dr. Wolf kita tunggu kehadirannya. Dr. Wolf merupakan uh, regional anestesi yang tergabung di ESRA dan kami bertemu tahun lalu di acara Oslo, di acara regional anestesi di Oslo, dan kami sangat berterima kasih. Hello, Dr. Wolf. Good night.
Hello.
We're at
Hi.
night in Indonesia, so you're.
Thank you very much, Ricky.
Hi, how are you? Very glad to see you.
Well,
You're
I'm fine.
in great moments. So, firstly, we want to acknowledge that warmly welcome to Dr. Bestadi Sukmono, Dr. Wolf Armbruster, Dr. Bestadi Sukmono as the chairman of the Indonesian Regional Coordinator for the WDRAPM. And then we have Dr. Dedi, as the regional consultant from Bandung. Bandung is near Jakarta. It's very nice and very comfortable city. And then we have Dr. Krisa as our moderator, anesthesiologist, and also in fellowship of regional anesthesia. So this is a great privilege to welcome Dr. Wolf as our guest of honor for this evening. So
Thank you very much.
Dr. Wolf will deliver our first lecture entitled From ER to OR, a topic that emphasizes the vital role of regional anesthesia in bridging emergency care and operative management. And then the second will be Dr. Dedi, will share about continuous of regional anesthesia. And then guiding us through this webinar with our respected moderator, Dr. Krisha, will facilitate the session, lead discussion, and manage the question and answer. So once again, thank you for all distinguished guests, speakers, and moderator for joining us this evening. It's very great moment, Dr. Wolf. Thank you so much for having this, for coming to our webinar. Thank you from Germany, and we hope so you can come to Indonesia, to Jakarta. Okay, for Dr. Krisa, this moment is for you. Very great moment, and you look so nice. And thank you. Bye bye. I see you again, Dr. Sukmono. Thank you, Dr. Dedi.
Bye bye. Thank you, Ricky.
Thank you, Dr. Wolf.
Okay, thank you so much, Dr. Rizky, a very kind introduction for all of us. So again, my name is Krisa, and I'm honored to be the first moderator for this year's third World Day Regional Anesthesia and Pain Medicine. So we've been doing this for 3 years in a row, I believe, with Dr. Mono. And I want to thank also the PERDATIN JAYA for supporting this event year by years. Thank you so much, PERDATIN JAYA, for your support. And I think from the introduction, Dr. Mono already mentioned that our 2026 theme is very practical and straightforward, which is equity, access, and relief, which I believe are all very essentials for us as anesthesiologists, and especially for the regional anesthesia consultant or pain medicine consultant. And in line with this theme, Jakarta picked a very, very interesting topic for today's webinar, which is from ER to OR, the role of regional anesthesia. So I believe we have already Dr. Rizky already introduced two prominent speakers for today's webinar. The first one will be Dr. Wolf from Germany. Thank you. So he will deliver about the regional anesthesia in emergency, and then followed by Dr. Dedi. So again, I would like to remind all the participants, I will invite you guys to post your questions in the Q&A box. During the presentation, it's okay, but we will address all the questions during the Q&A session after both speakers. All right, so probably Dr. Wolf, you may start your presentation.
Yes, I will. I will try to share my screen.
Yes.
And I hope, is everything fine?
Yes, put it in a slideshow, then it should be perfect. Yes, perfect.
So I start? You're fine? Okay.
Yes.
So thank you very much. Krisha and Ricky, thank you very much for the invitation, for the very nice meeting in the last ESRA Congress that was leading to this invitation. I'm honored very much. And I show you my first slide. Ricky, I told you in 2025, I've been the first time to Indonesia, only 3 days in Bintan Island. But it was one of the beautiful holidays I ever had. So I will give back all the warmth I felt, I hope so, with a presentation of regional anesthesia today. So I have nothing to disclose concerning this subject. So I'm turning to the title. It's about emergency blocks, or in the emergency room, or even in the ICU. You need regional anesthesia and a pain specialist. And I could say, yes, go into my last slide, because the answer is yes. It is the case that in emergency room and ICU, you don't have the specialists over there, very seldom. They are in diagnosing and in therapy of the intensive care patients, and pain is really underdiagnosed there. So the original title from here today is from emergency room to the operating room, role of regional anesthesia. And I will go over to some numbers that were impressing me. So it is truly the case that about 95% of physicians or 80% of nurses believe in ICU or emergency department that patients do have an adequate analgesia. But 70%, about 70% of patients experience, nevertheless, moderate to severe pain pre-operatively, perioperatively, or post-operatively, even in the emergency department pre-operatively. So for me, this is really shameful. And in about 50% of the patients, it's pain already addressed. And 80% of the patients at probably routine care program, they do have. So they are not really comfortable. And one of the worst scenarios is that in about 30 to 60% will still have 6 months to 2 years after discharge of the hospital chronic pain. So we have to start in the emergency room with our first therapy or diagnosed, and let's say pain is really underdiagnosed. What does it lead to? You all know it, what it does to the pulmonary system. It does respiratory depression. People are not able to cough, to breathe, and do atelectasis, prophylaxis by coughing, and for the cardiovascular system. when they do have pain, they're about tachycard, and they may have an elevated oxygen demand in the heart, which might lead to myocardial ischemia and infarction. So most emergency room patients experience moderate to severe pain, and what may we do? So many of those do have rib fractures. And most of the times opioids are given. So what will be the case or the issue with the opioids? They do less coughing, they do less breathing, they probably do have nausea and vomiting. And just to show you how you do in diagnosing the real anatomical structures, you're looking from the feet to the head. In this picture, you see the ribs, you see serratus anterior and latissimus dorsi coming. And I just want to show you this picture. This is the level of the nipple, and you go mostly backward on the ribs. So where is a good chance to do a blocking between latissimus and serratus, so anterior to serratus, I'll show you later why, and deep to serratus to the rib. So there are two different planes for this. ERAS protocols that are often, or that were raised by ESRA, they decrease opioid use. They are based on numerous evidence-based clinical trials, and they are best for frail patients as a result of the SARS-CoV pandemic. So this is really a new concept that anesthetists or those medical doctors working at the emergency department doing the first blocks in the emergency department, like a serratus anterior plane block. So this is not a study with multiple patients, just by about 100 patients, but showing that a serratus anterior plane block improves pain and increases spirometrical volumes in those patients, so they profit directly. So one important note, this is an abdominal wall, this is a thoracic wall. Where do the sensible nerves run? The sensible nerves run from the myelin. Well, we look into the abdomen. This is QLB muscle. This is the typical three-sliced abdominal wall. And at the level of the QLB, the anterior and lateral cutaneous nerves run into different, different levels. So if you doing a tap block in the emergency room relatively, lateral and not posterior, so you just reach the level of a rectus abdominis sensible block, but not of the lateral abdominal wall. If you do in a tap block in the emergency room, you do to execute a proximal, we say about a QLB block or a proximal tap block, that the volume you do inject may reach not only the anterior cutaneous nerves, but also to have a chance to block the lateral cutaneous nerves for any harmful injuries the patients had on the lateral abdomen. So that's very important. If you do them too much anterior, you just block anterior nerves. And about the same at the thoracic wall. I showed you the examination. The examination was on the serratus. This is serratus. On the serratus, you do block the lateral sensible cutaneous nerves of the thorax. And if you're doing it on another level, so at the deeper level between serratus and the intercostal musculature. You are not exactly at the level of the nerves as a plexus, but the nerves traveling from deep down between innermost intercostal muscle and internal intercostal muscles where they run. Physicians barely know that. So the best blocking site for thoracic wall blocks is on serratus to directly block the anterior nerves, or at the deeper level between serratus and anterior external intercostal muscle, to go to the level where they travel through from deep to anterior. So that was an important note. So the limitations of the erector spinae block. People thought erector spinae block, that is done at the level of the transverse process between the musculature of erector spine and transverse process. You do inject there a large volume of about 30 milliliters. And everybody thought about 6 years ago when it was introduced that it reaches a level like in this number 6 volunteer, as it might be used also for breast surgery, so for the anterior chest wall. But in this study published in 23 in Regional Anesthesia Pain Medicine, it was clearly shown in 10 healthy volunteers doing erector spinae block. We just saw a very consistently blockage of the posterior chest wall. So using it for about spine surgery perfectly, and seldomly, like number 6 or number 9, the only 2 from 10 that it would have been able to do breast or anterior chest wall surgery. So that was about disappointing for the first impressions that it might replace epidural anesthesia. No, it's the limit. It is perfect for spine surgery, but not for the anterior chest wall. So I would like to speak to rational indications for peripheral nerve blocks in the emergency room. So for thorax trauma, I talked about the serratus plane. And the most frequent blocks we as anesthetists do in the emergency room is for clavicle surgery patients or shoulder dislocation. For shoulder dislocation, we just do a superior trunk, so C5 to T6, about the interscalene nerve block, not a catheter over there for the shoulder dislocation, and the shoulder can be replaced easily after about 5 minutes. So for clavicle fractures that are very painful, we are called and we are blocking the cervical nerve C4 at the special level. I'll be showing it to you. And C5, you know, is the most skin near nerve of the interscalene plexus. So these are very common ones we perform in the emergency room as for femoral neck fractures, hip fractures, or wound revisions in the anterior proximal thigh, the fascia iliaca compartment block. Only to tell you, patients that have by a trauma, an amputation, and come to the emergency room, we're doing some sciatic and femoral, and for critical ischemia, for vascular deprived patients, we very often do for the legs a sciatic nerve block that is very, very helpful. So for cervical nerves block, we do that for carotid endarterectomy in the operation room, and we beware the patients from shunting, from catecholamines, and they are the best monitor. But in the emergency room, We can use the cervical nerves block for the nervi supraclavicularis C4 as a better local anesthetic concepts for dialysis catheter placement. The very impressive dialysis catheter placement and tunneled central lines catheter. This is one thing we also do use in the emergency room, because we, with a cervical nerves block at the level of C4, we block consistently about the lateral neck. And we can easily insert tunneled catheters at the typical places. So how we perform the block? So we do an examination. I'll show you the examination and the intervention with a typical, very easy subcutaneous tissue needle, because there's no motoric nerve out there. There's just sensible nerves, and the normal needle does not lead to neuropathic pain harming the nerves. And I show you what we are aiming for. So these are the bones and the sensible nerves. This is C5 and C6 going tracing back, and now C4 tracing back and forward. And this is also again 6 and 5, just to assure. And this is C4 spinal nerve. We put it back in the bone and put it out in a special level between the deep musculature and sternocleidomastoid muscle in this hyperechoic space. And you can easily go there at the depth of only 1 centimeter. We do an angle navigation of the needle, so seeing easily a double point over there, and put in some local anesthetic, and the lateral neck mostly is in good local anesthesia for very harmful catheters if you are not able to do a very good local anesthesia for it. So the second mostly used block in the emergency department is the fascia iliaca compartment block. And what does the fascia iliaca compartment block mean? So the lumbar nerves are coming out of the myelin. They go in really through the psoas muscle, and then afterwards, lying between psoas and iliacus muscle, go into their peripheral destinations. When you do block them, we can do easily wound management and easy operations, but we also do have a perfect concept for regional anesthesia for hip fracture patients and frail older patients, already blocking them at the emergency room to beware them from a too large amount of opioids, forgetting delirium and anything like delirium and delayed hospital stay. So showing you psoas muscle and the course of the nerves. The lumbar nerves come from the myelin. I hope the movie will go, or I will help a little bit. So the lumbar nerves are coming out of the myelin, going in the psoas muscle. They go out between psoas muscle and iliacus muscle. And now lying between psoas and iliacus in a little space right here where we can easily block them. So going further, you will find the typical destination of the femoral nerve. Lying here, femoral nerve, the artery, the vein, the artery, vein, artery, and nerve at the typical site where we perform the block. So we perform the block at the level of the femoral nerve. So where in this construct do you find it? You have vein, artery, and nerve under the iliac fascia. So showing you the typical examination. So unfortunately, my videos don't work smoothly, so I have to help a little bit with the leading you through the video. So we go to the typical level where we see artery and nerve. So I'm very sorry that the videos are not running very smoothly. I'm very sorry for it. But we go in then lateral. We see the sartorius muscle, and going further on a little bit upwards until we find the level of the lower iliac spine, not the crista iliaca anterior superior, but anterior inferior. I'm sorry that my videos don't work very, very easily. So I go on how the puncturing process will be after we start in the short axis. We go into the long axis, and for the plane, we go into for the out of plane puncture to in plane puncturing. So how will it be? So we go lateral to the femoral nerve at the level of the sartorius muscle. Afterwards, we change the routine of the direction of the probe. And we manage and watch the needle going in plane and in and about after injecting the local anesthetic to a retroperitoneal space. The fascia iliaca is running underneath the gut, the iliacus muscle is underneath the gut, and the local anesthetic will be very proximal. And we can guide a catheter through it. So again, the video is not running smoothly. Probably this might work. So we start with a local anesthetic. Look here at the right side. We just do a local anesthetic over the iliacus muscle. So it's a block in about 0.5 to 1 centimeter steps. That's for a beginner's block. That's not a very experienced block we have to do. So we go over to the long axis and the in-plane procedure. This is subcutaneously. We have to improve the needle, and we see how the muscle is going down and a little bit of volume, and this is just about 5 milliliters of volume, is pushing down the muscle, leading to a new space going to retroperitoneally. So this was just the local anesthetic, looking for the regional anesthesia needle going there. So trying to go again through the iliac fascia iliaca, doing some injection, changing the orientation from out of plane to in plane again. This is the case now. It's again subcutaneously and again going through and pushing down the muscle, opening the space again, forwarding the needle to go proximal in direction to the origin of the plexus. You can easily view and insert a catheter right there. You see the catheter is moved forward so that patients do not only have the experience of pain relief in emergency room, but also 1, 2, or 3 days later on the ward. So this was a patient. We inserted the catheter in a about 75-year-old man. He was not able to ride his motorcycle, but he was in the garage to just look at it, and it fell on his thigh, and the surgery was easily be done by the surgeons only by fascia iliaca compartment block. I said for the anterior upper thigh and for the periphery medially, no problem to do these procedures as wound management in the emergency department. So, and it is really, this is a fascia iliaca going underneath the gut, just to show you it is a retroperitoneal block. And what about in compartment syndrome? So there are some papers. There are no absolute contraindications for regional anesthesia in doubt of compartment syndrome. So just stay vigilant for clinical changes. Stay in near consent and clinical communication with the surgeon. This is the most important thing. So there's no convincing evidence that opioids or regional anesthesia delay the diagnosis of compartment syndrome, but you have to stay vigilant and you have to consent with your surgeon frequently. So, but for some fracture patterns, but very high energy injuries, surgical procedures do carry a higher risk, and regional anesthesia should be considered relatively contraindicated. But talk to your surgeon first. So as a summary, regional anesthesia or fascia plane block are fast, safe, and effective. They lower opioid consumption in the emergency room with less delirium and less ileus in the patients after hospital admission, with better breathing mechanics and shorter ventilation days if they go to ICU afterwards. But, and we are not at all perfect in our hospital with that, we're working still on it. We need a 24-hour, 7-day availability for a pain or regional anesthesia specialist there. We need SOPs, so written papers consented with the surgeons and the emergency department, how we call each other, when we do call each other, where we intervene, and which room we are going. And we have to apply training models to try this out before executing and being disappointed that it wouldn't work because of personal communication disorders. But most of all, a multimodal pain therapy must be standard with not opioids as standard medications. We have almost double non-opiate pain medicament therapy as a typical standard. And as I would say, if we do start in the emergency room, blocks may save lives. So thank you very much for listening. And just the German kind of books we do have, the international books we deliver with these informations inside. And for the newer time, if you are doing a translator program in Polish, it's also available in Polish language. So thank you very much for listening.
Okay, thank you so much, Dr. Wolf, for a very comprehensive presentation regarding regional anesthesia. From even you also mentioned about ICU, which I think we have a lot of questions regarding that. But we'll save the question and answer for the Q&A session. So we'll proceed to the next speaker, Dr. Dedi. So Dr. Dedi will discuss more about continuous peripheral nerve block, which I think also very interesting, which also might be in line with the first speaker. So Dr. Dedi, please, the time is yours.
Thank you very much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to thank everybody for inviting me to this wonderful World Day of Regional Anesthesia meeting. It is nice to be able to meet Dr. Armbruster and also Dr. Krisha. Nice to see you again. And not the last but not the least, Dr. Rizky and also Dr. Mono. Tonight, I'm filling in for my senior colleagues that should be presenting this. I will try to share with you guys about an update of continuous peripheral nerve block. Let me share it. Okay. First of all, I'm working right now in a very distant rural hospital, which is very far away from the capital city. Talking about continuous peripheral nerve block probably is just a dream for me. But few years ago, we've been using this, but nowadays it's very difficult to use this because it is due to the cost. Now let's see about the updates of evidence that I can share with you guys. First thing first, what is continuous peripheral nerve block? Well, if we put a catheter near the target area, which is a nerve or a plexus, or probably today is we can put it on in between those fascia, and we inject local anesthesia to provide prolonged, that's the keywords, prolonged and desired effect. That's what we call the continuous peripheral nerve block. What I'm going to share here is that all the publication that has randomized control trial in its publication, and it has most influential result that we can learn about it. First thing first, guidance insertion. Early 2000, probably we're still using a device called a nerve stimulator. How are we going to insert the catheter using a nerve stimulator? Because back then we haven't used ultrasound yet. And at that time, we're only talking about how are we going to put a stimulating catheter or non-stimulating catheter, or probably inside a needle that can be stimulated or something like that. Interestingly, even if we use nerve stimulator compared with ultrasound guidance, the data somehow showed us that it doesn't create any superior analgesia whether you're going to use nerve stimulator or ultrasound guidance. RCT involving over 450 subjects randomized for femoral catheter. They showed when the anesthesiologist inserted the femoral catheter using nerve stimulator, the catheter itself, it's stimulated catheter or non-stimulated catheter, it doesn't reveal a difference comparing the superior analgesia. So at that time, we cannot compare that guidance insertion can make a superior analgesia. Nowadays, we already can see everything much more clearer. Ultrasounds came. Now we know that if we were going to use a catheter or if we want to do a peripheral nerve block, ultrasound can help us a lot. Like recent published evidence suggests that benefits using ultrasound is very much appreciated. Successful is higher. Less time for placement. This means that if you're trained using ultrasound, you will, at the end, you will require less time compared if you're going to use a nerve stimulator. Induce less procedure-related discomfort. Definitely, You can alter your injection probably in shorter or more probably in not too many organ that's going to be injected, so create much more comfortable for the patient. And we also can see the places that we don't want to inject, especially blood vessels. Using ultrasound, we can see that. And it's very, very interesting that all the majority of the publication that they are using a short axis or a cross section for the nerve to be able to place catheter compared to a long axis image for doing a catheter placement. But regardless of that, if you want to inject the catheter, you can do it in plane or out of plane. So the catheter can be injected in plane or out of plane, but most of the publication, they already showed us how to place the catheter in short axis or a cross-section technique. To make sure that the catheter tip is in the right place, usually we want to check it. The publication showed that there are 3 types of checking method. How are we going to see the tip of the catheter? First of all, we can use fluids. Second of all, they use agitated air fluids mixture. And the third, small amount of air. Interestingly, between these 3 methods, there are no benefit investigated. So whether you're going to use fluids and you see it on the Doppler, or you want to inject some small air, they never stated that one is much more superior compared to the other. And probably using ultrasound 3-dimension, or they said catheter stylet pumping combined with color Doppler, probably it's more promising method. Have to locate the tip of the catheter, but it's not validated also. Now let's see here on the publication, one of the publication that stated almost all the sites of the human is already receive regional anesthesia and also continuous peripheral nerve block. For instance, the surgical site for the head and neck, they already inserted mandibular in the mandibular, maxillary, palatine nerves, and also the cervical plexuses. But for this for tonight update, we need to see whether the study already do a randomized control trial or not. On this publication, they cannot find a randomized control study regarding the surgical site of the head and neck. As you can see downwards on the shoulder and proximal humerus, we see lots of things, lots of information. Interscalene was there, yes. They done a randomized control trial also for the interscalene. And some comments say that there is, on the RCTs, demonstrated a 2-day continuous interscalene block decreased the pain for 7 days after major shoulder surgery compared with a single injection of ropivacaine block. Another thing that we want to see in this table is that supraclavicular, this publication was published in 2017. Supraclavicular is not yet that famous, probably because the data was taken before 2011, but the publicity or the publication of this study was published in 2017. It's still rare that people use supraclavicular catheter placement. What about other site of surgical site? For elbow, forearm, and hand. Interestingly, they stated that infraclavicular has provided something that involve with a randomized control trial. As you can see here on the table, infraclavicular injection and perfusion or infusion to all participants, they divided the participants into two groups. First participants stay in the hospital for 3 days. The second participants went home after the first day. They come out that the hospital cost care was 15% lower in the early discharge group. This thing that we need to realize that probably what we are doing right now, helping the patient to alleviate pain, helping the patient to be much more comfortable, also can be related to the cost of the hospital and also the cost for the patients to pay. What about the thorax and the breast? Definitely thoracic paravertebral, they have lots of things stated in RCTs for mastectomies and other things. But this data or this publication showed that there are no benefit using infusion over single shot of injection. This stated that probably on those RCTs is not yet well established about the volume, about the technique and everything. As I stated earlier, this study only took the data from lower than 2011. What about the abdominal and inguinal region? For the tap lock, definitely up until right now, unvalidated RCT regarding the tap lock and interfascial, especially the tap lock, is still debatable. What are the drugs that can be used for continuous peripheral nerve block? From the FDA, they stated that the only drugs that is safe to be given via the catheter for continuous peripheral nerve block is only local anesthetic. So long-acting local anesthetic like ropivacaine, bupivacaine, or levobupivacaine, they provided similar analgesia, although ropivacaine is much more easier to titrate compared to the other two. And also, lots of publications stated that using or adding adjuvant, just like opioids, for perineural infusion. This comes, well, infusion on the catheter just waken up the sleeping giants. They didn't provide any other comfort for the patient. They only wake up the sleeping giants of nausea, vomiting, and other side effects that opioids can reveal to the patients. What about delivery regimens? Evidence show that if you give a baseline infusion, it will improve baseline analgesia, decrease the incidence and severity of breakthrough pain, and decrease the sleep disturbance for interscalene supraclavicular and sciatic block. But in contrast to that, recent published data indicate that few benefits are afforded with basal infusion as opposed to repeated boluses for catheter in this anatomic equation. So it's a contradictory statement that should I use basal line, should I use basal infusion, or should I just give boluses for continuous peripheral nerve block? Another thing that I want to emphasize in here, there are data that's showing, regardless you want to use baseline, you want to use only boluses for femoral catheter, there's no difference. But a recent RCT suggests that including a basal infusion for continuous peripheral nerve block improve analgesia. How come there's lots of difference about this basal infusion, boluses, or combination of both? The conflicting result probably is due to catheter design, catheter insertion technique, local anesthetic type, basal infusion rate, bolus volumes, lockout times, and everything else. So without judging about one publication to another, as long as you feel comfortable using one type of regimens, by all means, just do it. Especially in Indonesia, we will find a different type of requirements of delivery regimens. As you can see here, some of the publication already stated that how are you going to use the regimens. For instance, I will take interscalines using ropivacaine for the first publication in this table. They compared ropivacaine with basal infusion, without basal infusion, compared with the control with no catheter. Primary findings of this is the two groups receiving ropivacaine had lower pain score, definitely, and consumed less supplemental analgesic than the control group, definitely. But there's no difference between the basal and bolus treatment group. In this kind of a publication, we need to filter ourselves whether we're going to use a baseline infusion or you just want to give boluses. Like I stated before, here in Indonesia, usually we don't require as much as a volume compared to the other probably Western countries due to our height and our body composition. Let's see about other thing. Adductor canal. Adductor canal, continuous peripheral nerve block. It's very interesting because lots of publication wants to talk about this adductor canal, especially adductor canal compared to the femoral continuous peripheral nerve block. They found out that using adductor canal will create less motor block compared to the femoral continuous peripheral nerve block. With less motor block, related to the quadriceps femoris, less fall can happen to the patient. So for the adductor canal, it's much more safer, and it requires less volume also, and it can produce the same analgesia as the femoral for the procedure under the foot. What about the devices? An increasing of number of disposable infusion pumps. They already come up with a disposable infusion pump that can create or that can be compared to all those electrical pumps that are being sold in the hospital right now. Although the portable pump right now, it's not cheap, not yet cheap enough for us to buy or the patient can buy it for their analgesia. But the good news is that portable pump right now can provide everything, almost everything that the electrical pump has on their machine. And another thing that I want to share to you doctors is that ambulatory perineural infusion probably right now is the thing that we need to see for another 5 or 10 years in our country. Why? Because the patient can go home earlier without any pain, and they can still have their catheter inside, and they're using a pump in their home, and it can be controlled via the internet. Interestingly, there are multi-center effort enrolled more than 1,500 subjects having interscalene continuous peripheral nerve block. Interestingly, only about 22 to 25 subjects had catheter dislodgement. And there are no catastrophic incidents, and there are no or few complications related to continuous peripheral nerve block, even when they go home with a catheter for interscalene. So, is there any benefit for us doing a continuous peripheral nerve block? Definitely, it has shown us that the evidence of perineural infusion is much more superior compared to the single injection peripheral nerve block, especially for interscalene, paravertebral, adductor canal, and also femoral and sciatics. Now let's compare the continuous peripheral nerve block to neuroaxial epidural infusion. For this comparison, we see that some of the researchers already compared femoral bupivacaine 0.2% with epidural bupivacaine 0.0625 plus fentanyl, they come out that there's no difference between the treatment of this group for total knee arthroplasty. As we can see right now, if you open up lots of a journal, if you open up lots of publication, they are shifting much more on the peripheral side compared to the neuroaxial side. I'm not saying that we should abandon neuroaxial block, but shifting from neuroaxial to peripheral nowadays is much more favorable. Now let's talk about the complication. All the data showed that fewer complication for the catheter placement due to the ultrasound guidance, although the catheter dislocation can still happen, but it's quite rare, about 25% for the femoral due to the movement of the foot, and also 5% for the interscalene. I also have experienced leakage of the catheter site. It can be attained by using an acrylate glue, which is, we don't have it here. At least in my hospital, we don't have it. I don't know in Jakarta. Catheter retention, when you want to pull out the catheter, sometimes it's a little bit difficult due to what? Sometimes it has a knot or it kinks. It can still happen, but it's very rare. Recent evidence suggests that perineural infusion is rarely making a patient local anesthetic toxicity, but the risk of infection is still there. It's around 3%. Now let's talk about something that it's related to our daily life. Doctor, I don't have continuous peripheral nerve block devices. Can I just use a single shot peripheral nerve block? Single shot injection of peripheral nerve blocks have multiple benefits over continuous infusion. First, less time required for administration, easier to do, and there's no catheter dislodgement, and there's no pump malfunction, and simply it's much more cheaper than continuous peripheral nerve block. Single injection peripheral nerve blocks, they already add something to make the single shot much more longer, like liposome bupivacaine and dexamethasone or buprenorphine. Everything is mixed with local anesthetic for the intention to make the block much more longer. But the drawback is that most reported adjuvant prolong analgesia fewer than 12 hours or less than 24 hours. So it's not as long as continuous peripheral nerve block, definitely. Now let's see. Single bolus injection of local anesthetic with or without continuous infusion for interscalene brachial plexus block. This study was published in 2024. Does it make any difference? Does it is it the same, or is it has a superior analgesia over the continuous? They randomize patient that undergoing shoulder arthroscopy. One group received ropivacaine 0.5%, 20 ml, and the other one received the ropivacaine plus the continuous infusion of ropivacaine 0.2%, 4 to 8 ml per hour. And in conclusion of this publication is that continuous infusion local anesthetic for interscalene brachial plexus does not provide superior analgesia after major shoulder surgery when compared to single injection, meaning to say we can still do single shot peripheral nerve block just to decrease the pain, but yes, it can help the patient or it can relieve the patient's pain, but probably it's not that long compared to a continuous peripheral nerve block. Let's see another publication in 2012, continuous peripheral nerve block compared with single injection peripheral nerve block. This is a meta-analysis of randomized controlled trials. As we see here, they compared the continuous and single shot peripheral nerve block. They concluded that the continuous peripheral nerve block associated with improved pain control, definitely, decreased need of opioid analgesic, less nausea, and greater patient satisfaction. you cannot argue with that if you do a continuous peripheral nerve block, it can we can shy away from opioids, so less opioids analgesic will be required, less nausea and vomiting and everything that related to the opioid usage. Last but not least, this publication was published in 2025. Association of peripheral nerve blocks with increased postoperative pain, opioid use in orthopedic surgery. This publication stated that although single injection peripheral nerve block were effective in reducing immediate postoperative pain and opioid consumption, they were associated with greater opioid consumption afterward. So yes, we can do single shot injection just to help the patient, but don't expect that it will last that long. Don't expect that it will provide analgesia superior or much more prolonged compared to continuous peripheral nerve block. So in conclusion, continuous peripheral nerve blocks still provide advantages for postoperative pain management or perioperative pain management. All the publications stated that ultrasound guided insertion is much more favorable and it's much more superior. Local anesthetic based drugs that we can give, whether it's ropivacaine, bupivacaine, or levobupivacaine. Cost is still the big factor, at least in my province, because continuous peripheral nerve block set is quite expensive. Ambulatory usage is very possible. Future usage for in our country, especially for the patient to go home and not to be admitted for a long time in a hospital. Would like to share with you guys take-home message. Do your block to help decrease your patient's pain. Start today and start with all the available things around you. Thank you very much for listening. Alhamdulillahi rabbil alamin. Subhanakallahumma wa bihamdika. Asyhadu an la ilaha illa anta astaghfiruka wa atubu ilaik. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, so thank you so much, Dr. Dedi, for a wonderful presentations. So before we proceed to question and answer, and while waiting for those question and answers coming in, so probably I would like to invite Dr. Mono. Probably you have some comments or even questions for both Dr. Wolf and Dr. Dedi. Please, Dr. Mono.
Thank you, Dr. Krisha. Our next to the Regia Anesthesia university-based education. Hello, my name is Bestadi Sukmono. I'm currently in charge of this whole show in Indonesia for the celebration of World Day Regia Anesthesia and Pain Medicine, third edition in 2026. I would like to thank Dr. Wolf, Dr. Dedi. We are very grateful for what you have done, especially Dr. Dedi on such a short notice. And Dr. Wolf for giving our country international kickstart. So it was a very good talk. That's what you did. And I think I have a few questions that I would like to ask. For fascia iliaca, is how can you make your block perfect? I mean, it's an interfascial block, you cannot always depend on the block. Sometimes it works perfectly, sometimes it doesn't work at all, and how long should you wait for the block to start? Even if you do with lidocaine or even if you have to use bupivacaine or ropivacaine. And with Dr. Dedi, yes, continuous block is an utopia for us in Indonesia with the cost that is the set that is so expensive for the national insurance that we have to advocate our hospital to purchase the set that is quite expensive, and because of that we cannot advocate enough. What would your suggestions for us as a regional anesthesiologist to advocate those are I've read about rebound pain associated with single shot. Would you accept that, or does the evidence that you have read said otherwise? And once again, it's been a wonderful talk to both of you. And since I'm 2 hours away from you guys, and I will keep following up the discussion. Okay. Thank you very much, Dr. Krisha and Dr. Rizky, for organizing the whole show.
Okay,
Assalamualaikum. Good evening.
thank you so much, Dr. Mono. So probably Dr. Wolf, do you want to answer Dr. Mono's question regarding the fascia iliaca block?
Well, yes, I'm pleased to. Well, fascia iliaca compartment block is, in my working group opinion, a kind of beginner's block. Instead of performing fascia iliaca compartment block, you can also do a femoral nerve block and a lateral cutaneous femoral nerve block. As a double intervention. So where are we? We are in between those two structures we can reach directly. So we are not really during puncturing at a nerve site. That's why we say it's a beginner's block. As I mentioned, the depth of the fascia iliaca on the iliacus muscle, it's a depth of about 1.5, or by obese patients in 2 centimeters depth, so that's near. And how to perform an optimal block? Well, reduce the depth of the machine. That the picture has about only 2 centimeters depth. That's the first recommendation. Second recommendation is do a needle navigation out of plane. So visible in out of plane punctures is only the needle tip. The bowl of the needle tip must be pointed to the beam of the ultrasound probe. So, and it's always, if this is the beam of the ultrasound probe, and this is the skin, and this is the needle coming, it's only the tip may be shown. Start always flat, go back, have a steeper angle, and advance the needle. So take yourself 2, 3, 4, or 5 steps till you reach your goal. It's never for central lines, for peripheral veins, for fascias. It's not, yeah, you get in or you're in the target. So our main issue, and I didn't show things about that, it's the needle navigation out of plane. So the play or the game of the needle tip with the plane and advancing it part by part with steepening the angle until you reach the goal. After it, you can align the probe 19 degrees and you're performing out of plane puncturing and in plane puncturing, as you saw in the injecting of local anesthetic. By rotating the probe, there was a little dislocation of the needle. It was above the fascia. The local anesthetic was going subcutaneously, not leading to any pain relief. And you always have to be assured, even if you do in a single shot with a needle in 1 or 2, better 2 axes, that you are at the right point. And even if you put in catheters, it is really recommended that after inserting catheters, inject under ultrasound control the local anesthetic and be sure that the local anesthetic reaches the plane or the nerves that may be reached. You saw it by the injecting in the needle, but not secondarily to catheters. So even also catheter testing where the local anesthetic goes to is very important. So these are my short recommendations about a perfect block.
Thank you. Yes, as I was mentioning earlier, this it is a beginner's block. You should target your nerves better. Yeah, but
But even
sometimes yeah.
excuse me, yes, it's a beginner's block, but even if these are beginners in my department or as residents with 2, 3, 5, or 6 years, we always go with a 4-eye inspection of the scenery. So there's also always a second person reassuring if the achievement is the one the performer thinks of.
So there are 2 eyes, minimal of 2 eyes, 2 point of views to
That's it.
correct. Okay, it's a
Okay.
nice point of view for you.
Thank you,
Okay.
Dr. Wolf. And next, probably Dr. Dedi, do you want to address the Dr. Mono's question?
No, I think Dr. Armbruster already explained a lot about interfascia block. Yes, it's quite intriguing. It's quite challenging for us to know whether the tip of our needle is in the right place or not. I would not add anything else. Thank you.
Okay, thank you, Dr. Dedi. And for so I think Dr. Mono have some questions for Dr. Dedi as well, right?
Yeah.
It's more like a comment, but probably Dr. Dedi can address.
Sure. The thing that I learned about pain, especially in our country, pain defined as unpleasant thing that the patient feel. It is very, very, very important for us as a doctor to always keep in touch, meaning to say we talk to them, we touch them, we really explain everything about with what we're going to do. Because once we achieve that, we have a doctor-to-patient relationship that is in a very nice fashion way. We can alleviate pain much more easier. It's not 100%, but easier. Continuous peripheral nerve block is very, very challenging for us because it's very expensive. So how can I help my patient? How can I attain this pain after surgical? Like I said earlier, in my take-home message, do it today. Whatever you have, whatever devices, whatever needle that you have within those vicinity, just do it. Ultrasound machine, OBGYN, obstetric people, they have it everywhere. Why don't we just borrow them and just for helping our patients? So first thing first, start today. Second, we don't have to have a really sophisticated devices. Everything that we have around us probably can start that. Interesting about the rebound pain. My opinion is that multimodal analgesia for our patient is very, very important. Not opioid based, but multimodal analgesia, just like paracetamol, preemptively before we're doing our blocks. It's very helpful for our patients. Sometimes they will just say, "Doctor, you're giving me paracetamol?" Yes, you will be surprised that paracetamol can help you. We need to emphasize that to our patient that those paracetamol that we can buy on the market is really helping them. Although we need to really see the dosage of milligrams per kilogram body weight. Sometimes we are giving a wrong dosage of paracetamol. So in my point of view, I will just make it clear, multimodal analgesia, doctor-to-patient relationship about analgesia, touch the patient, talk to your patient, what will happen, what do you expect? We need to explain that and start as early as possible without realizing what we're doing. As simple as our injection, as simple as a single shot injection, it really changed the patient's life. Thank you.
Okay, thank you, Dr. Dedi. Okay, so since we're limited time, so we're just gonna start addressing questions here. So the first question is, I will combine questions from Dr. Luther and Dr. Weina for Dr. Wolf. So the question is about whether when we are doing the block in the ER, we might masking the pain, which might be essential for diagnostic, right? Should just we wait until the surgeon or the consultant making the diagnosis, or we can do the block right away? And what is your opinion with whether, like, when we're doing the block, we're just delaying the diagnosis? And what's your opinion for it?
You're completely right. The bad things appear if you don't speak with the surgeon or with your medical partner, who is the primary partner for surgery. So we do not perform the blocks in the first front, so in the second. So we first talk to the surgeon, and even in the emergency room, even also on ICU, and even if the anesthetist takes the indication for the performance of general or regional anesthesia, we in our institution do always 1 day before elective surgery or even before trauma acute surgery contact if there's any interference with the block and a masking or demasking of other symptoms, like we have a proximal humerus fracture. The radial nerve is directly running on the lamina on the back of the humerus. And we ask our surgeon, is it possible to insert catheter? No, not the insertion of the catheter is the question, but we can insert the catheter with saline only, and the natrium chloride. And if postoperatively or after waking up or after sedation is gone, the surgeon reassures that surgery did not harm the radial nerve in this case. He talks to us, okay, now you can put in a local anesthetic in the catheter. So we are, yes, inserting first, putting in natrium chloride as saline only, so not doing a blocking on the nerve, just insertion, to be capable if the surgeon diagnoses perfectly after surgery, no trauma to the nerves, we can perform regional anesthesia, then we do regional anesthesia. So what is most important is the interaction surgeon to regional anesthetist or to anesthetist.
So I think communication and collaborating with the surgeon and the emergency physician. Yeah. All right. Okay. So the next question is for Dr. Dedi. Dr. Dedi, this question from Dr. Astrid. And would you please elaborate further why ropivacaine is easier to titrate compared to the other two local anesthetic?
Okay, I will just try to explain because this was stated in the publication that ropivacaine was easier to titrate because the duration of action of ropivacaine is 0.2% or 0.1% of ropivacaine. It's much more shorter. They say that it's much more shorter. So it's easier to titrate ropivacaine 0.1 to 0.2% compared to levobupivacaine or bupivacaine itself. They didn't state why it happens, but the two publications stated the same thing. If you're using ropivacaine in a very low percentage, it's much more easier to titrate due to the duration of the ropivacaine. It's much more shorter compared to the bupivacaine and levobupivacaine. Thank you.
Okay, very nice answer. Okay, next question from Dr. Rahman for Dr. Wolf. He asked about would it be more clinically effective to use a high concentration with a low volume or a low concentration with a high volume? So he mentioned a case, a patient with a closed humeral fracture, and he wants to perform a single shot injection of supraclavicular block. And he mentioned that this surgery normally scheduled 12 to 24 hours after the block is administered. And the next question, also he asked whether to give adjuvants or not.
Yes, we do give adjuvants as the first answer. We don't give them topically, we give them intravenously, like for preventing nausea and vomiting. In Germany, it's an off-label use to place dexamethasone perineurally directly, but there are colleagues doing it, and they say if you're doing it not intravenously, but directly para or perineurally, it may prolong the block. So for the other question, I go back to the words Dr. Dedi said. That's one of the most important thing, in my opinion, is not the volume or the concentration. It's the kind how you perform multimodal analgesia. We were going to the concept to already give non-opiates, and in bigger surgery or elective hip and knee surgery, already opioids orally pre-operatively. We always do give intraoperatively, intravenously, double non-opioid combination. In Germany, we mostly use ibuprofen as a COX blockade. There are other intravenous COX-2 antagonists available, and we mostly use metamizole or paracetamol. How there's a combination possible with indication and contraindication. But we always use a COX inhibitor and another peripheral like paracetamol or metamizole. It is very important that we go, so we go in the patient documentation, and we have to reassure, also talking to the surgeon, that immediately after surgery, the patient receives intravenously or orally further on the double combination of non-opioids and an opioid if it's a larger operation, or as a rescue medication. So this kind of multimodal concept, like Dr. Dedi talked about, is one of the most important things we learned, and we learned from the last ESRAs, or ESRAs opened us the eye that in many regional anesthesia centers, not all doctors, or there are not existing SOPs that any doctor for any surgery with regional anesthesia has intraoperatively to supply analgesics, non-opioid analgesics. And these very early. Why? Because an aspect of the COX antagonists like ibuprofen or ketorolac, what you use probably, is that you have to apply it directly before surgery starts, because it has to have a helping plasma level in the start when the periosteal will be cut. So when the periost is cut, that's the most nociceptive situation. And in these nociceptions, there's TNF alpha and interleukins going up. And if you supply medicaments like COX inhibitors, there's a lower secretion of these hormones, and people or medical doctors think, or studies think, that you might prevent the level, the post-operative height of level of nociceptive stimulation. So again, multimodal, already pre-medication, intraoperatively 2 medicaments, and supply these medicaments before the surgery starts, that there are existing plasma levels from the beginning on. And the question was, longer duration, local anesthetics, or larger volumes?
Yeah.
What I learned the last years is we supplied large volume of long-acting medicaments. So if you inject this in the morning, 9 o'clock, and you go by 5 o'clock, 5 p.m. to the patient in the room, patient says, "Oh, I do have no pain, but I have a problem. When will I be able to move my arm again?" And this is a psychological moment that is people don't think about if they do not perform post-operative visit of the patient, visiting the patient. In my opinion, patient feels better if after 1 or 2 or 3 hours post-operatively, he may have a motor purpose of the arm or the leg. If it's the duration of 6, 8, 10, 12, or 24 hours, they are really in doubt. Did we harm the patient? Will it come back? Do I have a nerve injury? And so my question is my personal question is no more larger duration. We prefer in our center a shorter duration and multimodal cut sets.
Okay, so multimodal it is. So I think this is a last question for Dr. Dedi. So in Jakarta, I'm not so sure in Bandung, see, we often use epidural catheter as continuous block, because of the price and, because of the availability. But sometimes we have leakage. So how do you what's your any tips and tricks to prevent leakage? And do you do tunneling? What's your recommendation for continuous nerve blocks? Dr. Dedi.
Thank you. It really brings much more on my historical background when I started my regional anesthesia. I don't have any continuous set of peripheral nerve blocks. So yes, I think everybody in my age knows how to use a epidural set for a continuous peripheral nerve block. First thing first, it should be realized that a epidural catheter has lots of holes. Probably the one that's available in Indonesia, if you counted, at least there's 3 holes for epidural. Catheter inside a needle, usually it will create leakage. The publication said if you want to decrease the leakage, it should be catheter over needle, but it's not readily available. First thing first, I would like to make first a deeper, not shallower, but deeper injection. At that time, I think it was 2010 or 2011 or 12. I injected a femoral catheter and also a sciatic nerve block for using epidural at that time because it's not readily available, continuous peripheral nerve block. I make it a little bit deeper. Deeper meaning to say that the catheter is embedded among the muscles. My intention is to decrease the leakage. After first day, everything is good. The second day, the rehab meds come to the patient. They start to move the patient up and down, up and down, up and down. And afterwards, I gave my injection. Wham! The leakage was there. I called my professor. He's in the Netherlands. Professor, I have a problem with this. Just use the glue. I don't have the glue. I don't have acrylic glue in here. I don't know how to attain that at last. So when I visited the patient in the second day and the third day, I pull out the catheter due to the leakage in those dressing is quite wet. I pull out the catheter. It's I'm afraid that I will just create another problem for the patient. So I just do single shot on the patient. I communicated with my teachers, my professor. Probably, yes, I will. You should try to do it with a device that it's good for peripheral nerve block continuous. But professor, we don't have that. If Dr. Chrysantia wants me to answer how to deal with those leakage using epidural set, which is gauge 18 for peripheral nerve block, up until right now, I don't know how to do it, but the leakage is always come. Sciatic, it's there. Femoral, it's there. Whether I'm doing it under tunneling, whether I'm doing it not under tunneling, whether I'm using tegaderm, whether I'm using lots of gauze to press the catheter, the leakage is still there. That's the thing that I think I need to share. And at that time, I used to cut the end of the catheter of the epidural. So I don't want to create too much holes because the holes of the epidural is spreading a lot at that time. But nowadays, anesthesiologists, they want to have lots of penetration on the catheter. Like I'm doing something wrong at that time. But well, that's how I learned my regional anesthesia using spinal needle at that time because I don't have insulated needle. I just want to see my needle under ultrasound and stimulating with all those insulated needle that being used and I'm sorry to say reused just to provide analgesia for my patient. Yes, it's dark side of my history.
But we learned a lot from the dark side, right?
Yes, welcome to the dark side.
Okay, so I think we already way past the time. Again, thank you so much, Dr. Wolf, for your time. Dr. Dedi, thank you so much for I think take home message from both presentations. We can actually start regionals from the ER. It provides a rapid, effective pain relief from the emergency ICU until the operating theater. And Dr. Dedi also mentions a lot of recent updates in the PNB. Mentions but the use of ultrasound guidance, the expansions of new insertion sites, and improved safety protocols. All right. Thank you so much, both panelists. So I would like to remind, like, this is our kickoff for our Jakarta World Regional Anesthesia and Pain Medicine Day. So next week, next Sunday, we also have a webinar, and then followed by on the 30th of January, we will have two workshops, and then followed by our symposium will be on the 31st of January. So with this, I'll conclude this webinar. So I would like to say happy World Day of Regional Anesthesia and Pain Medicine, everyone, including Germany. So hopefully we all will continue to do our best to serve our patient as per motto this year: equity, access, and relief. Thank you so much and have a good day.
Thank you. Thank you,
It was an
Dr.
honor, and see you
Bye.
next
Dr.
Esra.
Dedi. Thank
Nice
you
to meet
all.
you.
Bye-bye.
Bye.
See you again.
Terima kasih semua. Izin ya.
Terima kasih, Mbak.